Thank you very much to Sadie and Zuzu for their kind invitation. My role today is to give a brief overview of aspects of adolescent care that we're going to hear in more detail from the three excellent abstracts that follow. So I'm going to describe treatment approaches to support young people, particularly those who are struggling with adherence to antiretroviral therapy. Then we're going to look at the management of pregnancy in young women with perinatal HIV. And then finally, briefly look at some of the mental health issues faced by adolescents and young adults. I work in London, and similarly to many well-resourced settings, we actually have very few children. The majority, as you can see from the purple bar, are now young adults aged around 20, and really up to the eldest young person I look after is now 36, having been born with HIV. So really in Europe and the US, we're very much looking after cohorts of young adults who are successfully transitioning into adult care. However, globally, those aged 15 to 19 years are the only age group where mortality continues to rise, and these are driven by the long-term survivors of the perinatal epidemic. And we see, unfortunately, that for adolescents, outcomes are poorer at all stages of the care cascade than either for younger children or for older adults. And this is something we really need to address. But actually, poor adherence and falling out of care is really a normal part of adolescence. So this is looking at sugar control in insulin-dependent diabetics. And what you can see is that from early adolescence, age 12 to 13, sugar control starts to deteriorate. But actually, when young people aged about 23, 24, you can see that things very much improve. And this is very much what we also see in those living with HIV. And actually, this is a normal part of risk-taking behaviour that goes with adolescence. And we need to take risks because many of the tasks we do in adolescence are completely new to us. And we would never actually leave the comfort of our own home if we didn't take some risk. And young people living with chronic healthcare conditions actually take more risks and earlier than their peers. And this in a way makes sense to me that if you live with a condition that might be life-limiting, you may want to experience things rather faster, and your assessment of what is a risk to you personally may be different. And there's a really good reason why adolescents take risk, and that is that our brain development continues through our teens and into our mid-20s. And the thalamic drive that makes us take risk, take new experiences, develops first, and then we get the executive functioning, the frontal lobe, which is how our wishes and impulses are then more considered with our experiences. And for young people living with HIV, there are some additional tasks in adolescence, and many of them live with additional risk factors. So the cohort I look after, half have lost one or both parents, more than half are migrants into a country. Many have experienced stigma both within healthcare, but also within families and in relationships. A third have learning difficulties, and all of those with perinatally acquired HIV have to negotiate their sexuality, their first sexual relationships with a potentially sexually transmissible disease before they have ever had sex. However, the really good news is that if we can support young people between the challenging years of around about 14 to 24, what we do see is that adherence improves along with that maturation that occurs in your mid-20s. So this is the graph of a young woman who very much struggled with her adherence throughout her childhood, but has been undetectable for the last 3 or 4 years, and her CD4 count, having been under 200 for many years, is now above 1,000. So how do we support young people to stay in services, to keep well, and to negotiate this very exciting time that is adolescence? Many, many good things happen, but there are many new experiences. And there is good evidence, and we'll discuss in the abstracts later, that adolescent-friendly services, not treating people like children, listening to their decision-making and their wishes, are extremely important in keeping young people engaged in care. In the service that I am part of, which is very much a multidisciplinary service in London, what we've found for us is that an afternoon service, that you don't need a booked appointment, that is open access, that is integrated, particularly with peer support available within the service, that you can not only get your HIV care, but also people are interested in your sexual health, your contraception, your vaccinations, your social care, your finances, if you become pregnant, your pregnancy care, testing of your partners, and a more global holistic GP care. And the segregation of services is extremely difficult. And adolescents, particularly if you don't have the money to negotiate multiple services, to change your appointments, to being able to walk in, is incredibly important. And even during the COVID pandemic, we never closed during lockdown. Now, whilst about 80% of the young people I look after have an undetectable viral load and manage their antiretroviral therapy very well, 1 in 5 at some stage in their life, and it may be when you move away out of home to college or to university, struggles with their adherence to antiretroviral therapy. And this is our schemata of how we try and support young people to prevent drug resistance, which we're going to hear about later, and to manage their health. Accepting that for some young people, there are periods in their lives where they won't be able to take antiretroviral therapy, and that care in the clinic is not just about medication. It's about engaging people in the conversation so that they manage their health. That may be their sexual and contraceptive health. It may be other important things in their lives, and looking at the structural barriers such as poverty, transport costs in attending clinic, are really important. Do you have the food, if you're on an antiretroviral regimen that's based around food such as rilpivirine, do you have access to the food to take your medication? We use an integrated model. We're very lucky. We have excellent psychologists. Occasionally, we have used things like financial incentives, and more recently, long-acting antiretroviral therapy, so injectables. We're really lucky now. This is, as all young people listening will recognize, this is Fortnite, the game, and this is talking about the fact that we now have regimens based around agents such as dolutegravir, such as the boosted protease inhibitors, darunavir, that have a really high genetic barrier to resistance. And this means that young people can actually have episodic adherence through those crucial years of 14 to 24 and acquire very little resistance. So you can see this is Jane. She was on a regimen based around boosted darunavir, was on and off for much of 2006 to 2012, but actually only acquired a resistance mutation against 3TC and now is fully suppressed on a small dual tablet regimen of dolutegravir with lamivudine and tenofovir alafenamide. Moving on to our second topic, this is looking at pregnancies in women with perinatally acquired HIV. I'm really thrilled that many of the young men and young women who have been living with HIV for their whole lives and in our clinic are going on to have healthy and happy families. However, when we compare those women who've been born with HIV compared to those women in the UK who've acquired HIV, usually through sexual transmission, what we see is that in those with perinatally acquired HIV, women are 3 times more likely to have a detectable viral load near delivery, And some of that is the long-term impact of having acquired resistance through the less potent antiretroviral regimens that we had in the end of the 1990s and early 2000s, and so a legacy of childhood. And some of it is the pill fatigue that goes with adolescence and into early adulthood. We've learned a few lessons along the way. This is a young woman, a 24-year-old young woman, and this is from 2018. And really in childhood, you can see her viral load, the red dots. She had struggled in adolescence with adherence, but actually when dolutegravir-based regimens and single tablet regimens became available, she'd actually suppressed from 2017 onwards, and she'd had a good improvement in her CD4 count. She was then 5 weeks pregnant, and this was just at the time that the dolutegravir alert for possible neural tube defects from the Botswana cohort came out. So we switched her to boosted atazanavir, tenofovir, and emtricitabine. Unfortunately, you can see the large red spike just under the pregnant lady. She couldn't tolerate the boosted atazanavir and had a viral rebound back to over 100,000 copies, and we therefore switched her back to Triamec, and she resuppressed and fortunately gave birth to an uninfected infant. But this was a real lesson to us about caring for young people with histories that are, show that they have struggled in the past. She had never tolerated a boosted protease inhibitor-based regimen. The risk of potential infection with viral rebound to her uninfected partner and infant, thankfully this didn't occur, but it was a potential risk. And actually, when she presented, she was already 5 weeks pregnant. And we know now that the neural tube in infancy closes by the 26th day of pregnancy. So actually beyond this time. And so moving to a second pregnant young woman, this is a young woman who had learning difficulties, had had a long-term issue with adherence to antiretroviral therapy, was severely immunosuppressed, and had a very high viral load. She'd had a complex antiretroviral treatment history, but again, had only acquired very minimal resistance to the nucleoside analogues, efavirenz and nevirapine. And you can see here that for her, switching to a long-acting formulation of antiretroviral therapy that we were very kindly and able to obtain on compassionate use is the first time her virus has consistently suppressed for many years. And she then has become pregnant. She then has become pregnant and is successfully progressing through her pregnancy, her baby yet to be born, but we've continued the long-acting antiretrovirals in a recognition that she's never been able to sustain adherence on oral antiretroviral therapy. And the most important thing is to keep her virus suppressed so that she remains well in her pregnancy and that her infant remains uninfected, although there is no data as yet as to the use of long-acting antiretrovirals in pregnancy, and she's aware of this. Not to leave out the men, we know very little about the impacts of lifelong HIV infection on fertility in men, and this is some very preliminary data due to be published, which does show some concern about some features of semen analysis in men, and this certainly requires more data, although many of the young men we look after have successfully gone on to father children. And finally, just looking at mental health, the ALFI cohort was a cohort of adolescents living with HIV matched with their uninfected siblings. And what we saw is that rates of depression and anxiety were similar between those living with HIV and their HUE exposed siblings, but higher than the general population. But this in a way isn't surprising, as in the UK, risk factors for poor mental health in adolescents include Black ethnicity, a migrant population, parental unemployment, being a looked after child and living in poverty, which are features that many of the young people I work with have to have in their care. When we look at our cohort, in addition to anxiety and depression, what we have seen is an increased rate of psychotic episodes. Now, episodes of psychosis typically occur in late adolescence, in the general population for the first time. But we have seen a rather higher rate, and this is certainly something to watch. Some of these episodes have been young people with drug or alcohol dependency and off antiretroviral therapy, but some have also been in young people well controlled on their antiretroviral therapy. So in summary, for young people growing up with HIV, the future is really incredibly exciting. We have agents which support young people to grow up, allow them to have an undetectable viral load, allow them to negotiate sexual relationships without the risk of onward transmission. But the path is complicated and it's quite long. And I think what I have learned from the young people that I'm lucky enough to work with is that what you need is hope, whether that be for you, hope of a cure. And this is the London patient who was the second man thought to be cured of HIV following a bone marrow transplant for an underlying malignancy. But the other aspect is that young people living with HIV want to be just like their peers. They're experiencing many of the incredibly exciting things in life, and they have many of the same issues of other young people and need the respect that all young people want in terms of achieving their care. I'd like to thank the wonderful teams that I work with, but particularly the children, adolescents, the young adults, and now the not so young adults that I have the privilege to care for. Thank you for listening, and I'm very happy to take questions now.